Good afternoon and welcome to the World Stroke Day today. From Aster Healthcare, I welcome all our panelists and Dr. Malti, Aster Group Chief Medical Officer and Group Chief Quality Officer, to launch today's comprehensive stroke program. Over to you, ma'am.
Dear friends, it's my proud privilege to welcome you all for the launch of the Pan-India Comprehensive Aster Stroke Program on the World Stroke Day. The theme being faster care, better outcome. This program seeks to emphasize the critical nature and the high rates of stroke. The neurosciences departments across the Aster group of hospitals, comprising of the neurologists, the neurosurgeons, interventional radiologists, and the rehab team, have come together as a unified program to be launched. The objective of this program is to deliver standardized quality care at the right time. Friends, needless to say, the most important focus shall be on the delivery of care at the right time, since speed counts and that envisages a better outcome. Friends, thank you for joining us today for the panel discussion. We will start the program now with the message from our chairman, Dr. Azad.
Greetings to everyone from Dubai. I'm extremely happy to address you on this very auspicious day, the World Stroke Day, as has been declared by WHO. Stroke, as we all know, is as bad as a heart attack, but unfortunately, this has not been given that importance. We all worry about heart attack, but when it is a brain attack or a stroke, nobody is actually that much aware the way in which it can be detected early as well as prevented. So there is a requirement for more of awareness regarding stroke, and World Stroke Organization has actually started this campaign about 10 years back, and WHO has taken it up. So it's very good that this year they have come up with the campaign to tell everybody that 1 out of every 4 of us will get a stroke in our lifetime, and don't be among that 4. It's very, very profound statement. Even though we know that 85 to 90% of stroke happens after the age of 50, there is a possibility of people who are in the younger age also getting stroke. So depicting them along with the older people, we can take out the notion that this is only a disease of the old age and everybody has to be careful. And if you learn it early, that's the best thing. And that's what WHO is trying. So we, as a large organization spread over 7 countries with a large number of hospitals, we have a responsibility to educate the public about the importance of stroke. And I foresee that this will go to a stage where it will be like the heart attack or the ischemic heart disease, where people are so aware, and as soon as they have something like, even a symptom of a chest pain, like, which may be non-cardiac many times, they rush to the hospital and they are being taken care of. That should happen even in stroke. So the FAST, which are the 4 symptoms of stroke, which is given: the face, the change in the face drooping, as well as the face in the hands, the weakness, and all those related things. We have to make people aware about that. And that is the whole campaign which is wanting. I once again wish all the best to the team that is taking care, starting from the neurologists, to the physicians, to the nurses, to everyone who is involved in this campaign and wish the function all success. Let me also congratulate Dr. Malti, our ever enthusiastic Head of Medical Services, and other colleagues of her who have taken this up to spread this message. Thank you very much.
We now will have Dr. Harish Pillai, who is the Chief Executive Officer for our Aster DM Group of Hospitals India. May I request Dr. Harish to say a few words, please?
Thank you, Dr. Malti, and firstly, congratulations to all of you colleagues for assembling together to share your knowledge on this important day as declared by the WHO. The disease burden for a country like ours is just unimaginable. The data, what is there in the public domain shows that over the past 5 years, the incidence of stroke in India has increased by almost 100%. And when we look at the bucket of non-communicable diseases after coronary artery disease, stroke is the second largest contributor for mortality and morbidity within our country. And we are still an emerging nation in terms of our economic development status, and we just can't afford to have those kind of morbidities within our working population. Therefore, the attempt which all of you are doing today to share knowledge and best practices with each other will go a long way. A few words about the India clinical program. I believe that Aster units in India have amongst the largest neurosciences program amongst the peer group within this country. Whether we talk about physicians, neurologists, neurosurgeons, interventional radiologists, the rehab program, social workers, it's a fairly comprehensive program. In addition to that, what is unique for Aster is our Aster volunteer program, where we have committing free time and also our combined resources, whether it's our own infrastructure, our equipments, and also our manpower for the benefit of the communities in which we serve. I hope that such an event in which all of you are taking part will give more thrust towards increasing awareness in the community, and that will go a long way to decrease morbidity and mortality in the communities that we serve. Once again, I would like to thank Dr. Malati, all the Chief of Medical Services, the entire neurosciences faculty for taking part in this momentous day. Best wishes to all of you. Thank you.
Thank you very much, Dr. Harish, for those valuable messages. We now will be starting off with the program, which will be a panel discussion, and it is my proud privilege to introduce to you Dr. Kumaravelu. Dr. Kumaravelu is going to be the moderator for this panel discussion. A brief about him. Dr. Kumaravelu graduated from AFMC and is a topper in advanced medicine. He has completed his DM from the All India Institute of Medical Sciences, an ex-member of the Indian Stroke Association, and a fellow of the Indian College of Physicians and Indian Academy of Neurologists. He has over 30 publications, both national and international. He is a proud author of an original research paper in the use of tenecteplase in ischemic stroke in India. His special field of interest is advocacy of stroke. I would now invite Dr. Kumaravelu to take over the session of panel discussion and introduce the panelists as well. Over to you, Dr. Kumaravelu.
Good afternoon, colleagues. Thank you, Dr. Malti, for this nice introduction. Now, I'll try and do justice to my panelists, who are all an elite lot. Before I introduce the panelists, I'll just give you an overview of the stroke as it happens in India and the various complications thereof. Yeah. Next. This 82-year-old lady. Smatika, can you play the video? You can see that when she was asked to show her teeth, the right half of the face refused to move and the left half is moving around. Next, we'll go to the next video. As we asked this 82-year-old octogenarian to lift both her hands, you will find that the right hand is not able to sustain and falls onto the side. Next video. Now this is after giving the injection to this lady. Actylize was provided to her, and within an hour of getting Actylize, this is what she is. She is following the observer and she is able to lift both hands comfortably. Next. Stroke occurs when the blood vessel in the brain is blocked, what we call as an ischemic stroke, which happens in 87% of our stroke victims, and another 13% has got stroke due to rupture of a small vessels due usually to hypertension. Next. As the chairman has alluded to, 1 in 4 of us will have a stroke in our lifetime. The theme by the WHO was "Don't be the one." I always say, let us not be the one. They say charity begins at home. Let us not be the one, and we'll try and let others not be the one on this particular day. That is the motto for October 29th, World Stroke Day 2020. Next. Stroke can strike at any age. It's not a disease of the old as it was believed to be. It can affect children, young people and adults of any age. For information, 60% of stroke survivors are under the age of 70. 10% of stroke survivors are under the age of 44. And 39% of people who die from stroke are under the age of 70. Next. 6.5 million people die as a result of stroke every year. Okay, this is much more than the population of Andhra Pradesh. Just to give a gravity of the situation, and 80 million people are living in this world with stroke at any time in their lifetime. Next. 116 million years of healthy life are lost worldwide to stroke-related death and disability each year. Next. Why should we act now? Because every 6 seconds, one human being dies of stroke. Every 2 seconds, one of us gets stroke. And there are 65 lakh people who die of stroke every year. 1 in 4 will have stroke at some time. It's the second leading cause of death for people over 60 years, and 80% of such poor stroke victims live in low and middle income countries. Stroke attacks a person regardless of age, sex or wealth. Next. We should act now because stroke is a global epidemic that threatens lives, health and quality of life. We should act now as we have the knowledge to reduce the risk of stroke and to effectively treat patients. We should act now as much can be done to rehabilitate stroke survivors and improve their overall quality of life so that they do not become a burden on the society. We should act now to raise professional and public awareness. That's what we are doing right away about stroke. Next. Stroke is a major cause of serious long-term disability. It's the second most common cause of death past 60. And according to the World Health Organization, 17 million people suffer stroke worldwide annually, of which 1/3 die and 1/3 has significant neurological deficit. This led the World Stroke Organization to launch the 1 in 6 campaign way back in 2010. Next. Coming to India. As per Dr. Murthy's study, we have an estimated 1.4 to 1.6 million new strokes every year. 12% of such strokes are in people less than 40 years and 25% are in the young. Mortality is anything between 18 to 41%. Stroke mortality in India is 3 times that of the West, probably because of the lopsided distribution of available frugal medical facility. There is no difference between the rich and the poor. Next. Let's face the facts. Stroke is treatable. That's what we have to sink it in. Lives can improve with better awareness, access, and action. Next. As this is what I have alluded to, what's important is any patient treated in a specialized stroke unit care increases the chances of good outcome by 14%. And those who had the privilege of receiving the clotbuster drugs, namely RTPA, have a good outcome by 30% improvement. And those who required clot retrieval has a chance of a better outcome by about 50%. So what's important is stroke should be detected in time and treated appropriately. Next. So, ladies and gentlemen, together we can win the fight against stroke and make our people who are liable for stroke at least prevent it and treat it if as and when it occurs. We'll see it when we start the panel discussion with our allied panel. Our first panel member. Next. Can you remove the slides, please? Yeah. Our first panel member is Dr. Sashi Kumar. Sashi Kumar is a senior consultant neurology at Aster MIMS Kottakkal with 28 years of experience and a special interest in stroke. And he is the lead consultant at MIMS Kottakkal. He instituted the thrombolysis program in the Kottakkal unit. Next, we have Dr. Lokesh, a consultant neurologist at Aster CMI Hospital and the lead there. His area of interest are stroke and neurosonology. We'll hear about it when we started. He is heading the comprehensive stroke care program at Aster CMI Bangalore. Then we have Dr. Sindhu, our young dynamic neurologist at Aster Prime. She has a postdoctoral fellowship in epilepsy and she is looking after the stroke program at Aster Prime. Dr. Bobby Workey, a very energetic lead consultant at Aster MedCity, our frontline hospital. He has a fellowship in neurocritical care from Mayo Clinic and he is an interventional neurologist, actively involved in stroke intervention, neuro ICU care and neuroinfections. He is presently the secretary of the neurocritical care subsection of the Indian Academy of Neurology. Dr. Ravindra Kamble is working as neurointensivist at Aster RV Hospital, Bangalore. He has a vast experience in managing stroke interventions, apart from other neurointerventional procedures. Dr. Paul Alapat is a deceptively young consultant neurologist. He is focusing on endovascular stroke interventions. In fact, he was stuck in an intervention, mechanical thrombectomy, a little before the start of this program. To finish the list, Dr. Srijit, consultant Department of Neurology at Aster MIMS Kannur. He is a native of Kannur and he is a product of Calicut Medical College, both his MBBS, MD and DM. And he is working as a stroke neurologist at Aster MIMS Kannur. Now, with the introduction of this elite panelist, we'll set the ball rolling by starting with Dr. Sashi. Sashi, is stroke preventable?
Yes, sir. Stroke is largely preventable, and we have a very strong evidence, large study, that is the interstroke study, which has showed that the stroke is preventable. They have gathered data from 32 countries across the globe, and they found that the strokes are usually caused by 10 risk factors. They are hypertension, smoking, hyperlipidemia, diabetes, alcohol excess, stress, obesity, heart disease, and lack of physical activity and poor diet. 10 of the factors that we know I just enumerated. They found that 90% of the strokes are caused by these 10 factors. And all these factors are modifiable. So we assume that the 90% of the strokes are preventable. Also, should I continue?
Yeah, please.
This year's stroke slogan actually tells us that physical activity reduces stroke. This is again is telling us to go to the public and tell the public that stroke is preventable. To prevent stroke, actually, WHO tells us to target two populations. One is the so-called high-risk patients. High-risk patients are the ones who come to the hospital with the diabetes, hypertension, metabolic syndrome, and all that. So here, the primary treating physician, apart from treating the primary disease for which he has come optimally, he should also impart the knowledge that stroke, is a candidate for stroke and how this can be prevented. Especially during that, for that, in the first place, we should disseminate this knowledge that the stroke is preventable to the primary care physician. He should be educated first. So during the treatment of the condition for which he comes, then he also looks for other treatable causes like atrial fibrillation, other cardiac illnesses, and if possible, and if indicated, you can do a carotid Doppler study also. He should counsel the patient regarding contraception, migraine, because we know that migraine, especially classic migraine patients, if they are on contraceptives, are at high risk of contracting stroke. Also, you must look for inflammatory conditions in the body, because we know that inflammatory conditions are associated with stroke. This can be collagen vascular disease or chronic skin conditions or even gum disease. Then, of course, where appropriate, you can also elicit the history of sleep apnea. Then looking for rarer causes like homocystinemia and thrombophilia are not really feasible, but then there is a history of young strokes in the family or something, you can also look for that. So this is the community. This is the first target WHO tells us to inform this stroke prevention program. Second is the community at large. Community at large, just like our chairman said, a large organization like ours should make a difference in this regard, because it's a little beyond the neurologist, and I leave this to the relations department to organize mass education programs, etc., to make awareness in the public. They should be told two things. One is that stroke is preventable. Second is that they should be able to identify stroke. You know, it's not that they go to the hospital, another hospital, and they tell them that he has stroke. They should identify the stroke, and they should also know in advance which hospital to go, and also they should know in advance there's a treatment like thrombolysis and thrombectomy, etc. Why I'm saying is this: we just analyzed our few strokes in nearly 100 strokes in the last 5 years. It was very slow progress, mainly because of these two conditions. They were coming late because they were going to a nearby hospital and all that. Secondly, they were deliberating on the consent. They just takes hours to come to the conclusion that they can accept the injection. So all this, if they are already aware, the door time can be very much minimized.
Yeah, thanks, Shashi. You brought in two important aspects. What is important is the primary prevention should start from the society and not from the hospital. And what's important is the primary prevention also envisages a knowledge about the management that is available to treat acute stroke and how shall we go about it. And let us hear from Dr. Lokesh. How will a layman identify a patient having had stroke?
Yes. So it is a very important that the general public identify what is a stroke symptom. Many of us know that a heart attack, the chest pain is there, and people will rush to the hospital. But a stroke, most of the time, the symptoms are in negative. That means the stroke symptoms depend on which part of the brain which is affected. So the people should be aware that the right half of the brain controls the left side of the body, left half of the brain controls the right side. So any damage to any part of the body can give rise to symptoms. To make things simpler, we have introduced a concept called FAST. So FAST is an acronym which tells that F stands for facial drooping. Anything sudden onset of drooping on one side of the face. A, arm weakness, weakness on one side of the body. Slurring of speech, as speech slurring, it could be difficulty in comprehending or difficulty or slurring of speech. And T is a time to call. So this is a fast acronym, which is, like we emphasize so that the general public can quickly, get to know that, okay, they are having a stroke symptom. Apart, the important concept here is a sudden onset. Anything that comes suddenly weakness on one side, suddenly they notice that they are unable to speak or difficult in understanding and speaking. And other common symptoms are giddiness. This is one of the symptoms that people tend to, like mistaken. It could be because of high BP or low BP. So, but these symptoms like sudden onset of giddiness, blurring of vision, or like sudden onset of like swaying. So these are the symptoms which will tell us that okay, there is something wrong with the brain, and then that needs to be taken seriously, and the person who or she whoever encounters the symptoms should rush to a stroke ready hospital immediately.
Yeah, it will be worthwhile adding. I'll just give a thing what happened in Vijayawada about a year ago. Okay. We had done a bit of advocacy about how to pick up stroke, the FAST acronym what Lokesh was alluding to. It so happened that a 16-year-old college-going girl doing BA psychology identified the onset of stroke in her father at home and could get the patient across to us within the window period, and he was fortunate enough to receive thrombolysis and got cured 100%. I mean, without any deaths in the patient did. So I'm not saying it just because we are in a stroke, but this is actually not what the paper emotions. Now, Lokesh, Sashi was alluding to about some carotid Doppler and something, and you're an expert in neurosonology. Can we hear something about it? You're muted. You have to unmute yourself.
As slightly spoken by our previous speaker, Dr. Panelist Dr. Shashi Kumar. So the stroke risk factors, predominantly the vascular risk factors like hypertension, diabetes, and hyperlipidemia. So what it does is it creates a condition called as atherosclerosis, where there is a deposit of a fat-laden lipids within the blood vessel. Now, when it comes to a primary stroke prevention or secondary stroke prevention, so we have these tools that we use like Transcranial Doppler and carotid duplex. I call it as a neurosonology, which is a point of care ultrasound. So what is a carotid duplex? It's a point of care ultrasound machine where we can scan the neck and then we can see these deposits, and they are called as either in intima media thickness or a plaque, and we can quantify the narrowing or the stenosis. So this is a live indicator that yes, there is an atherosclerotic process. That means there is a fat deposition or a lipid deposition happening within the vessels, and especially these things can be done in for high-risk patients who are having hypertension, diabetes, or a family history of stroke or behavioral risk factors like smoking, alcohol, and other things. The second important tool in neurosonology is called the transcranial Doppler. We call this as a doctor's stethoscope for the brain. With this transcranial Doppler is a specialized instrument where we can place it over the skull and we can get the flow information from the vessels, from the intracranial vessels. And through this, we can estimate whether they are narrowed or whether the flow is normal. And one important thing here is we can get to detect a small emboli, which is a small clots, and we call it as a embolic detection. So this encompasses, like a neurosonology where we do a cavity duplex and a transcranial Doppler. We can do it as a part of a primary prevention of stroke in all patients with vascular risk factors or patients who already had a stroke to look at their vascular status or whether we need to do any interventional procedures to prevent any secondary strokes. Over to you, sir.
That was a nice review of neurosonology as applicable to stroke. Now, having made, the layman has made a diagnosis and brought the patient of stroke to our emergency room. Let's see what Sindhu is going to do to investigate this patient.
So, yeah, once the patient comes to us to present to an ER within a window period, we need to tailor all our investigations because every minute counts in stroke. So first do a GRBS and then collect a blood sample for routine investigations, but do not wait for the investigation results. Then shift immediately the patient to CT room and get the CT brain done. And if the CT brain doesn't show any hemorrhage, we are good to go for thrombolysis if no contraindications for thrombolysis is there.
Okay,
so
good.
I think we should not do much investigations.
Right. What is the golden time window concept, Sindhu? Would you like to say a few words on that?
Yeah, to the present guidelines, we can thrombolyze within 4.5 hours from the symptom onset according to the AHA guidelines 2018. But this 4.5 years is considered as a golden window period. As rightly coined, time is brain. The earlier we thrombolyze, the better the outcomes are. Hence, so every minute counts in the stroke. So the goal is to reduce the door to needle time to less than 1 hour.
Yeah, good. See, the thing is, as Dr. Sindhu correctly pointed out, the earlier recanalization, the better, because the recovery rate and the side effect profile comes down significantly if you do it within 3 hours. It is as per the ECAS and other studies, we have extended the window up to 4.5, but of late this is coming under a bit of cloud with 2 publications which has come against the 4.5 hour window. Anyhow, as of now, the guideline says up to 4.5 hours one can thrombolyze a patient. And as she said, every minute delay leads to death of 19 lakh neurons. I repeat it, every minute delay leads to death of 19 lakh neurons in the brain. So we must not waste even a minute, leave alone half an hour or whatever it is. Now, Bobby, having come to this, patient has come within the golden window to us. How will you treat this patient?
Yeah, so what we do is as soon as the patient comes, we activate the stroke code. The most important thing is the ED physician or the neurology resident on call immediately goes down. We rapidly rule out hypoglycemia, seizure, and our prime focus is to rule out any other stroke mimic that precludes us from taking the patient, from administering the timely intervention for stroke. So what we look for is the stroke causing a measurable deficit that is not clearing up spontaneously, and is the patient within that golden hour, is it really presented within a time that is amenable to any sort of intervention. So we always initiate the stroke code, we inform our radiology department, and we perform a comprehensive neurovascular examination that includes a CT as well as a CT angiogram. If the patient's time of onset of stroke is unclear, or if it's a wake-up stroke, or if it's a posterior circulation stroke with multiple deficits, then sometimes we ask for an MR with an MR angiogram to assess the status of the brain and the vessels. If the neurology team and the ED team feel that the patient has a measurable deficit, which is likely to require any urgent intervention, either in the form of IV thrombolysis or mechanical thrombectomy, we immediately inform the stroke suite and get the cath lab ready. The stroke team has already been alerted, and the imaging findings, including the angiogram, are rapidly interpreted and passed on to the neurology and the interventional team. And then we take a stat decision. If the patient has a small vessel occlusion, then the patient is offered IV thrombolysis. If there is a large vessel occlusion, then the patient is immediately either given a bridging therapy with IV thrombolysis and then offered the option of mechanical thrombectomy, or we go for other medical management if depending upon what the scenario tells us. But most important is that the findings on clinical examination are correlated with comprehensive neurovascular assessment with the CTA or an MRA and imaging, and these are of paramount importance in triaging the patient and deciding on further treatment.
What are the agents available for thrombolysis in our country?
Right now, the agents that are available include IV recombinant tissue plasminogen activator and tenecteplase. RTP or recombinant tissue plasminogen activator has been in use and is familiar to most neurologists for over a decade, whereas tenecteplase is a newer agent. I think Brigadier Kumaravelu is one of the people who have written a paper in the use of tenecteplase. Tenecteplase, of course, cheaper, easier to use, and can be administered very rapidly compared to actylase. So these are two agents that all neurologists must know in their management and treatment of stroke.
Yeah, as Bobby has rightly pointed out, tenecteplase has an edge over actylase at the moment in that it's given as a bolus dose without wasting much time and can be administered in a periphery where monitoring for 1 hour may at times be difficult. So having seen that we have thrombolized our patient, we take the patient, as Bobby suggested, taken the patient after thrombolysis to the suite because he did not improve that well. We did a CT angiogram and found that the patient had a left M1 occlusion. Let's see what Ravinder has to do about this patient. Ravinder, your baby.
Yes, sir. So now, after investigating the patient, that we know that the patient is having a large vessel occlusion, whether it is internal carotid artery occlusion or middle cerebral artery occlusion, or maybe both. Then we take the patient to the cath lab suite and then prepare the patient for doing a thrombectomy. Now, what actually is thrombectomy is we do this procedure by through the femoral approach, where we take a small puncture into the femoral artery in the groin and take the catheter right up to the internal carotid artery. And then what we actually do, what is mechanical thrombectomy? The procedure is we try to put a small stent, which is a stent, into the clot so that the clot gets adhered to the stent, and then we remove the stent along with the clot. So this is called as the stent remover technique or mechanical thrombectomy. So there are other methods of doing it, what we call as an aspiration. So we even take a large bore catheter very close to the clot and try to aspirate it. Or sometimes we need to combine this both stent remover technique and also the aspiration technique to remove the clot. So whatever the technique we do, we try to open the artery so that the artery recanalizes and the blood flow to the brain restores. So the major goal is always to salvage the brain tissue from getting infarcted so that the patient shows a good clinical improvement after doing a mechanical thrombectomy.
Now tell me, Ravinder, you want to say, somebody wants to say something? Ravinder, which are the, suppose a patient has come to you, he has got a NIHS score of say 3 and he is not able to speak and he has got a large vessel occlusion, left M1 occlusion. What will he do? Or what will be the recommendation? What would you like to do?
So in these patients who has even NIHS score of 3 and who has a large vessel occlusion, say middle cerebral artery, in these are the good candidates to do a mechanical thrombectomy because sometimes they don't respond to the IV thrombolysis. So in these cases also, we try to go in and do a mechanical thrombectomy.
Okay. We seem to have lost touch with Ravinder at the moment.
Like what we call as a TK.
Okay, fine. So Ravinder, I'll just chip in for you. If imaging shows a large vessel, large infarct, large volume, and an aspect less than 6 on CT, with poor collaterals on angiogram, but the patient is within 6 hours of onset of stroke, should we carry on with the mechanical thrombectomy or do we do otherwise? Yeah, what we need to do is in such a setting, what we had just now, we should not thrombolize such patients because the outcome is not likely to be good in the absence of good collaterals and an aspect score less than 6. So we will not thrombolize such patients. And as Ravinder was already into, there are very few contraindications for mechanical thrombectomy, unlike the thrombolysis where we've got lengthy list of contraindications. Now, having said that, we'll ask Paul, how will you manage the blood pressure in the first 24 hours during thrombolysis and post-thrombolysis?
Blood pressure management in stroke prior to thrombolysis in a patient in the window period is there are BP cutoffs which have been decided according to the American Heart Association, Stroke Association guidelines, and you have to keep the BP below 185, 110. And that is an arbitrary cutoff kept where complications of bleed are more if you go above that BP, and you are more safer to thrombolyze when the BP is lower. So you have to ensure that the BP is low at 185, 110, and then you go ahead with the thrombolysis. And for the next 1 hour, you have to ensure that the BP is less than 180, 105. And subsequently also through the IV thrombolytic, the next 24 hours, you have to keep a watch on the BP and make sure that it does not shoot up. Now, BP if you are going for a bridging thrombectomy and you have done a successful thrombectomy and there is good reperfusion, you have to usually you keep the BP less than 140 or near normal values. And if you are not done any of these procedures, that is, you are not done a mechanical thrombectomy or IV thrombolysis, it is always best to keep the BP as it is unless it crosses a BP of 210, 110, 120, because most of these strokes, especially the small perforator strokes or the large vessel occlusions, you may cause collateral failure when you or the perforator failure when you decrease the BP. So it is always better to maintain the cerebral perfusion. BP is always a balance between your cerebral perfusion and the risk of hemorrhagic transformation due to when you have a blood-brain barrier breakdown.
Yeah. What, as Paul has correctly said, blood pressure should be managed appropriately in the settings. It's usually the cutoff is around 180 upon 105 is what the JNC 7 mentions and the 8 also. And we should use an agent which one is comfortable with. I always say there are 3 molecules mentioned in the JNC, Joint National Commission, but whatever you are comfortable, like I am very comfortable with labetalol. So I prefer labetalol usage for control of blood pressure in that acute setting. If you are comfortable with enalapriate and other things which are available to you, you can do that particular agent as is convenient. 2 things, availability at the local level and the comfort of the treating physician. 2 important parameters which will decide the drug that is being used. Now having said it, we have said something about, I had made in my slide some 14% chance of a good outcome when a patient is treated in a stroke ICU. Can you tell me what is the role of a stroke ICU and how it is created?
Sir, that is one of the best points made. That is the role of the stroke ICU. Irrespective of whether you have IV thrombolysis or a mechanical thrombectomy or anything, it has been found out that just by having a good stroke ICU and a comprehensive and good stroke ICU, you have better outcomes on patients. That has all to do with the stroke ICU. The management is due to the multidisciplinary effort you put in a stroke ICU and the continuum of care you take from the ED to the rehab team and the multidisciplinary rounds you take and the focus on stroke, because most ICUs are historically focusing on cardiorespiratory parameters, ventilatory parameters, etc., without a focus on stroke. So when you have a stroke ICU, you know the BP which has to be managed, which Sir had emphasized earlier about the BP cutoff and how important it is. Because most of the cases, even from the ED, when the stroke ICU people only manage, even you respond to the call of an acute stroke from the stroke ICU, because you have to be with the patient from the start to the end, and that continuum of care is there in the stroke ICU. And you will have stroke bundle sets where you go through bundles or stroke order sets in which you go through the stroke checklist for each and every patient, look for early mobilization, do this dysphagia screen and look for DVT, start early DVT prophylaxis. All these measures make important treatment outcomes in stroke patients. So especially with regard to BP also, we know what is there to manage. A stroke patient is unlike a cardiac or a respiratory patient. He will be sitting silently, and if he's aphasic, all the more bad. No one will care for him in another ICU because he will be there. But while a cardiac patient will be complaining of chest pain, a respiratory compromised patient will be having breathlessness. So a doctor or a nurse will always be alert. But in a stroke, it is to do with the brain. And especially with the brain, it may be quiet. And you have to look out for the neuronal loss, and which may be permanent by the time you intervene. So it is about the rapidity of care and the know-how in the importance of stroke ICU.
What are the complications that you are envisaged to see in an acute stroke patient?
As acute stroke care physicians, interventionists, everything, the most dreaded complication what we all face is the bleed. And that is the #1 complication which we have especially when we are going ahead with thrombolysis or mechanical thrombectomies. And all that has to relate to what was said previously, the good management of BP and a good stroke ICU. So other than bleed, other complications which we routinely see in stroke are the aspiration pneumonia, and then we will have a DVT with pulmonary embolism, and we can have then all the other things like hyperglycemia, hypothermia, etc. has to be managed in a good way. The most important thing is related to bleed with specificity with stroke. All other factors can be seen in other illnesses and all, just like in a other ICU. And for the bleed, it is always about BP management and knowing your stroke and what type of stroke it is.
Yeah. You must remember about cerebral edema also. That's very important. Coning can be a major hassle, and if not detected in time, we may lose the patient. So the earliest dip in sensorium of a stroke victim should warn you of a possible herniation and should be addressed appropriately depending on the condition and the facilities available in your center. Now, having treated an acute stroke and made him stable, now we'll come to certain special situations. Srijit, what is wake-up stroke? One of the members had asked, what is wake-up stroke? How will you identify the time?
So many people go to bed as usual and wake up with stroke symptoms. And these patients we refer to as having wake-up stroke because they woke up with stroke symptoms. And previously, we were not used to offer TPA and other clot-busting treatments to these patients because the time of onset has to be considered to be the time they were seen last normal, and often the time is the time they went to bed. So a study published in 2018 in New England Journal of Medicine called Wake Up Trial provided evidence that using MRI technology, using a parameter called diffusion flare mismatch, we can correctly identify patients among these wake-up stroke patients who are eligible for IV thrombolysis. And from 2019 onwards, this has been incorporated into North American stroke guidelines as well. These wake-up strokes are not a minority of cases. Up to 25% of cases occur as wake-up events. So this data is very important for providing effective treatment for patients.
How will you ascertain the time of onset in a wake-up stroke where the actual time of onset is not known? That was one of the questions from one of the members. I saw the questions as it is being published.
Many wake-up strokes happen in the early morning hours. Say, happen just 1 hour before he woke up. Imagine like that. Then in that case, when we take the MRI, a sequence called diffusion-weighted imaging will show a bright signal, whereas another sequence called flare will not show a signal. So this mismatch, diffusion showing signal and flare not showing signal, this is called diffusion flare mismatch. That indirectly tells us that the stroke onset has been somewhere around 3 or 4 hours, not more than 5 hours usually.
So what's important is, one of my students conducted a study on diffusion flare mismatch in various time windows. Majority of students, our client patients, had a diffusion flare mismatch in the first 4.5 hours, but we did have a significant number up to 6 hours and few patients up to 9 hours as well. So stroke and the clot apparently doesn't seem to follow the timeline that strictly. So this brings us to what is known as a tissue characterization. At present, we are a bit far away from tissue characterization of the clot as of now. Now coming to this thing, how can we, now having discussed the various treatment modalities, let us see how we can reduce the onset to door time in stroke patients. How awareness among primary doctors as well as general public can lead to better stroke management. What's the role of doctors?
Primary family doctors play a pivotal role in effective stroke management because when they identify stroke quickly in the periphery and refer patients to a stroke-ready hospital, that is the most important step to provide patients with clot-busting treatments and other treatments which have got a narrow time window. And secondly, we are often asking relatives and the family members to take quick decisions on life-changing issues. And when faced with this, often family seek guidance from the family doctors to whom they are in acquaintance for a long time. So often the family doctors can help the family members to take a quick decision so that effective treatment decisions are taken quickly and for the benefit of the patient.
Yeah. What's important is our referral doctors should be educated to an extent that when a patient has an acute stroke, without wasting much time in trying to find out the nuances, like if a patient with an acute stroke can have a blood pressure of say 160, 100 or 170, 110, without wasting much time, if the BP is around 180, 100 or so, shift the patient to a nearest stroke enabled hospital. Need not necessarily be an Aster hospital, but let the patient go to a nearest stroke enabled hospital where the patient can be treated appropriately and try and have chance of recovery. That's what is essential, that we need to educate our referral doctors. I think majority of them are educated, but we need to keep on emphasizing the same. Now, do we have a clinical pathway in our hospitals for treating stroke? And if so, what is the importance?
Traditionally, we neurologists enjoy making a diagnosis, taking our time, and the diagnosis made often decides how the patient is treated. But stroke treatment is special in several ways. Speed is everything. Coordination among various departments and various professionals is of paramount importance. For that, we require an established, well-delineated stroke pathway in each hospital so that everything is happening very smoothly in a coordinated manner and teamwork is everywhere. So that is the importance of having an established stroke pathway in a hospital so that delays are minimized and maximum eligible treatment is provided to each and every one of the patients who come to us.
Yeah. Good. Now that I think we have broadly covered the various aspects of acute stroke management, I have some questions in the question answer box. I'll read them and address it to the concerned panelist. Now, the first question goes to Sashi. Sashi, does stroke run in families? Can young people get stroke?
Answer to both are yes. First of all, I'll tell that first stroke can happen to young people. Traditionally, you used to think that it is a disease of the old age, 60 plus. It is no longer so. One of the things that is happening is that the life stress and lifestyle diseases are occurring much earlier. So hypertension, diabetes and all that are seeing much earlier. Then of course there are special situations in the young people, like people who have heart disease or thrombophilias, that is conditions which increases the chance of blood clotting, etc. They're also in younger age. In other words, there is no age bar, like Dr. Kumar will showed a slide. All cases, even children get it, seizures, even neonates get strokes. So second thing is, does it run in the families? Again, it can run in the families in two ways. One is the the common thing that is their background is the same, so they are consuming the same diet and facing the same stress. So they are likely, the father, the children, father, etc., are likely to be, for example, obese, or certain conditions like diabetes, hypertension, etc., run in the family. So father is a diabetic, mother is a diabetic, the children are likely to be diabetic, and so on. This is so from a common background with family history of risk factors, it can run in the family. So it's very important that when the patients come, we ask about the family history. Then there are very special diseases, which of course is only neurologists will be worried about that, like CADASIL, CARASIL, and all that. That is a kind of blood vessel disease which occurs in the families, which is the typical history. They will come with a history of recurrent TIAs, migraine, gradually developing dementia, and all that. Then you think about the diseases like CADASIL, CARASIL, that is autosomal dominant arteriopathies and all that. So yes, the answer to both are yes.
Yeah, thanks, Shashi. Dr. Avni has asked Sindhu, what is the golden period in stroke treatment? Does it go beyond 4.5 hours in certain special settings?
Yeah, the golden period is still 4.5 hours. But yeah, in very special settings, like according to the Braun trial or diffuse trial states, the mechanical thrombectomy is possible till 16 hours and 24 hours in very specialized cases. But the thrombolysis, IV thrombolysis is still at the window of 4.5 hours.
Yeah. Thanks, Sindhu. Now, there is one more question in the panel, in the box, which says, do you prefer thrombolization or endovascular urokinase or endovascular embolectomy as an emergency procedure in case of acute stroke? Dr. Kamble, would you like to take this question? Kamble, can you unmute yourself? You have to unmute yourself, Dr. Kamble, you're muted.
Yes, sir. Yes, sir. Can you hear me now?
Yeah.
Can you just repeat the question, sir, please?
Do you consider thrombolization or endovascular embolectomy using urokinase? That was the question in that box. It has not been anonymous.
Yeah. In previous, before the thrombectomy procedures were done, usually we used to do a urokinase or other fibrinolytic drugs. We could go into the artery and do a thrombolysis. But after the advancement of the stent reverse, a different type of stents and aspiration catheters, we nowadays prefer to do a mechanical thrombectomy rather than doing a thrombolysis, because the results of recanalization are much more better with mechanical thrombectomy compared to the thrombolysis.
Yeah, in other words, you say that intra-arterial thrombolysis as a standalone procedure is no more practice.
No more practice. Yes, sir.
That's what I think they wanted to know. I presume that's what the person who asked the question wanted to know. Yes. Dr. Bobby, are there any contraindications to therapy with thrombolytic drugs?
Yes, sir. So first of all, probably the only absolute contraindications for thrombolytic drugs would be in the case of if there is some severe coexisting intracranial bleed, such as subdural hematoma, or if there has been a major recent bleed from some other area of the body, like the gastrointestinal or genitourinary tract, or if the patient has undergone any major surgery within the last 14 days. All other contraindications are probably relative and can be managed, like for example, high blood pressure can be brought down with medications before thrombolizing. Severe hyperglycemia should not necessarily be a contraindication to thrombolysis. Intake of oral anticoagulants or even the newer oral anticoagulants can actually be reversed by medication and then thrombolized again. And there is also the option of going straight to the interventional suite without IV thrombolysis in case there is a large vessel occlusion, like Dr. Ravindra Kamble said. So there are very few absolute contraindications. Everything else should be judged in the context of the patient's stroke, and decisions should be taken in a combined manner, looking at everything, putting everything together into context.
Okay, that is already. I'll ask you one more question. This I addressed to Jerome Engel when he came to AIMS when I was doing my DM. See, the point is, when a patient has got a concomitant myocardial infarction and an ischemic stroke, acute ischemic stroke. Okay. Now the blood pressure, the cardiologist wants a BP around 140/90. At that time, we used to want to maintain the BP around 180/100. Now, what shall we do?
So the cardiologist wants the BP down and you want the BP up.
No, in the post-MI, they don't want it so high. 140/90, 160/90 is the maximum they want the BP to be.
So I think again the question.
Our neurology used to keep it around 180/100 was our concept then. Though I was part of one of the study which was published about 2 years back, where the blood pressure really doesn't matter whether you keep it so high or a normal blood pressure, doesn't really affect the outcome.
Yes.
That's the paper we published along with the Australian group.
I also think that blood pressure is only a guideline. Whatever for example, if the patient has an acute MI, I think that should take precedence. As far as the brain is concerned, we have options of doing thrombectomy or something else, and recanalizing, and keeping the blood pressure high. If you have recanalized the artery, doesn't really matter. Even in a lenticulostriate artery, if you've thrombolized, I think you can get away by reducing the BP and keeping it within a reasonable range.
Yeah.
So I think you can definitely follow the cardiologist's advice.
No, I always, Jerome, what he said was, it all depends on your relationship with your cardiology colleague. That's what he said. In a lighter, just to keep the matter light. Yes. Now, one more question to Dr. Lokesh. Lokesh, you said about FAST, isn't it?
Yes.
Do we have an Indian equivalent of FAST? I'm very fond of that sign.
I mean, you mean to say what actually you're trying to say? Indian equivalent?
This one.
Okay. Right.
See, why I say this thing is, I always popularize it with the public when I keep addressing them is, ask the patient to stand up and say namaste with folded hands. Okay. If this thing could be done, your BFAST is covered. Not only FAST, your BFAST is also covered. Okay? Balance. Yes. Everything is eyes, balance, everything gets covered in that. Such a simple thing. Ask your patient, and in Corona, it becomes the order of the day. That's how we greet each other. Namaste. That's what we greet each other, isn't it? Let the patient be told to say namaste with the folded hands, up, stand, and say. So standing, you've got your excluded limb, lower leg weakness, and gait, ataxia is covered, looked after. With folded hands, upper limb weakness is taken care of, and coordination is also ensured. And when the patient is looking eye to eye with you, you can make out whether the facial involvement is there or not based on the facial movement. And if the patient utters the word namaste or whatever you say, vanakkam, whatever you want to say, it becomes that the patient's speech is also assessed. That's how I say. And I feel, and I read it in one of the letters to the editor somewhere, and I got enamored, and it seems to be quite practical in our country. That's how I took it. Okay. Now, one more question in the chat box is, who should undergo stroke prevention and what tests are done for the same? Sashi. Is Sashi there?
I can take this question, sir, if you want.
Yeah, please.
Hello, sir.
Yeah.
Like I said, stroke prevention is for everybody. Actually, the thing is, stroke, Indians are particularly prone for strokes. We used to say that there are two kinds of risk factors. One is modifiable and one is not modifiable. The non-modifiable risk factors are, ethnicity. Indians are more prone. So all of us are prone for stroke more than the Westerners. Second is age. The older one, are more prone. Then third is those people with the lifestyle diseases like diabetes, hypertension, etc. This is what I said earlier. Target two populations. One is the one who comes to the primary physician with what shall we say, with the diabetes, hypertension, etc. They are the high risk people. It should be targeted. Then also there may be people who have a family history of such diseases, and these are all should be picked up. There are the people that should be targeted, and they should be given maximum preventive. And also people who have, I have not talked about the secondary prevention in my first talk. So another target group that should be addressed is the people who already have had a stroke. Because having one stroke is the greatest risk factor for a future stroke. Because all the mechanisms which has led the first stroke is still operating. So secondary prevention is also important. Should I talk about the secondary prevention, sir, or the answer is?
Please go ahead. And Lokesh wanted to supplement something, you can supplement thereafter.
So the secondary prevention, this is actually under the control of the neurologist. The primary prevention is largely by the primary contact physician or by the people who interact with the public. So after treating, after all our heroic measures like intravenous thrombolysis, thrombectomy and all that, we institute certain measures which we call the secondary preventive measures. The idea is to prevent a future stroke. Like I said earlier, one stroke can, once a patient gets a stroke, he is likely to get it again. Not only stroke, they will get a MI or peripheral vascular disease, because all these are diseases of the medium-sized arteries. So the secondary prevention predominantly revolves around optimal treatment of the lifestyle diseases like whatever I said in the primary prevention. And lifestyle modification is easy to enumerate, very, very difficult to enforce, very difficult to achieve also. But anyway, nevertheless, we must tell the patients to control their diabetes, control their hypertension, etc. to the best. Be compliant with their medicines, go for regular exercises, at least to walk for 10 to 45 minutes a day, adjust their diet so that they eat more of vegetables, fruits, and avoid, smoking must be quit, and also best to avoid alcohol also. This moderation business most of the time doesn't work, because people who drink even in small amount are likely to indulge in dietary excess. So whatever is achieved by this moderate drinking is lost by eating alone. So, and also obese people should be encouraged to shed some weight, at least 10% of the weight. Second cornerstone of treatment is the so-called drugs which prevent clot formation, that is the antithrombotics. Antithrombotics, we have the platelet inhibitors as well as the oral anticoagulants. Platelet inhibitors usually used are aspirin and clopidogrel. Usually we tell them to take either one of them live. But then if there is a concurrent cardiac illness, we ask them to take both, because some of the cardiologists are very fond of aspirin and get away without action. Even in stroke, immediately after an acute event, American Heart Association, Stroke Association has recommended dual antiplatelet therapy for a period of 21 days. This is slightly debatable. Some people agree. The latest NICE guideline of 2019, which says that they still prefer clopidogrel single drug after 15 days of aspirin use. So this is about the platelet inhibitors. Then the next drug that we use are the oral anticoagulants. Oral anticoagulants we use for prevention of cardioembolic strokes. Cardioembolic strokes occur in conditions with concurrent cardiac illness like atrial fibrillation, valvular atrial fibrillation or non-valvular, MI with a LV thrombus, certain cardiomyopathies, valvular heart diseases. Then of course presence of prosthetic valves. traditionally we use vitamin K antagonists with the intention to keep INR in a target range of 2 to 3. But if it fails, you escalate it to 2.5 to 3.5. But sometimes we have to add aspirin to enhance the anticoagulable state, because sometimes even with the full anticoagulation, there may be failure, especially in the presence of things like a mechanical valve. And of course, nowadays we prefer oral anticoagulants like direct oral anticoagulants, so called direct oral anticoagulants like epidaxan, dabigatran, and over the traditional acetylcholine and warfarin. Rightly so, actually. So many reasons.
Yeah, thanks, Shashi. What's important is that, for want of time, we'll just we'll keep it at this. Or amongst the oral anticoagulants, the direct oral anticoagulants, as Shashi has correctly alluded to, makes the life of a patient very comfortable, because vitamin K antagonist has got a very stringent food restriction, because the drug food interaction is significant in vitamin K antagonist, that we say. And if a patient has to really follow it, it becomes a misery for the patient to live. You can't eat this, you can't eat this, you can't eat that, and it becomes difficult. Now, Lokesh, you wanted to say something about it?
Yeah, just supplementing what Dr. Shashi Kumar has mentioned. So for secondary stroke prevention, the bare minimal investigation is, one is, as we know, stroke is a vascular disease. A vascular assessment is a must, like a carotid duplex, a bedside test, where you can quantify if there is a plaque, if there is a keratostenosis, and then whether a person has to be on oral anticoagulants or not, cardiac imaging. So echo and ECG, and a 24 hours Holter monitoring. These two investigations are a must to decide whether the etiology, because 80% of the stroke either atherothrombotic or cardioembolic, right? So put together, and then special risk factor workup like procoagulant workup, that should be under discretion of the treating physician, depending upon the age and then lack of risk factors and other things. And just lastly, for primary stroke prevention, just like the cardiologist, how they do a treadmill test, they are doing this echo, just to see the vascular assessment. Yes, for stroke, if there is, we can do a National Stroke Association stroke risk card, where a person is having a diabetes or hypertension or irregular heart rate, and then we can supplement to this a carotid duplex and transcranial Doppler. We can look at the vascular imaging, and as I mentioned, atherosclerosis, presence of intima media thickness, presence of a plaque are the signs of atherosclerosis. And then based upon that, we can definitely initiate some stroke preventive medications, whether it could be cholesterol lowering medications or antiplatelets or blood thinners. Yeah, thanks.
Thanks, Lokesh. Now, having seen that, we have a concordance to the tune of 70% between the heart and the brain. That's why they are always usually clubbed, I think. Okay, the vascular risk factors for cardiac and cerebral ischemic stroke are more or less identical. Now, having said this, when a patient of acute ischemic stroke comes within the window, within about 7 or 10 days after suffering an acute MI for which he was thrombolized, what shall we do? Bob or Paul, would you like to take this? Acute MI, 10 days back, had an anterior wall MI, okay, thrombolized, treated, but he develops an acute ischemic stroke and lands up with you. What shall we do?
So in this case, we will treat as any other stroke comes in the emergency. Previous guidelines had there was a sequence set of guidelines showing that you couldn't if it was an anterior wall MI, but now all the guidelines have updated that it is of not much of difference what MI or however it is, you can go ahead and thrombolize. But there is some caveats to this, in the sense that if you are having a large clot in the heart and it is already demonstrable, especially when you go ahead with the thrombolysis, there is a chance for clot fragmentation, further recurrent stroke, etc. can also happen. So it should be well discussed with the bystanders, the risk factors, especially with a large clot in the heart. But especially in a large vessel occlusion, you can go ahead with a mechanical thrombectomy without any. But when there is small vessel occlusion and when you cannot reach those vessels by endovascular approaches, then IV thrombolysis can be done, but the risk benefit is not as the level of evidence is not as high as in a normal listing. But still, it should be treated as a normal stroke. That is the end result.
One of my earlier patients, whom I have thrombolyzed way back in 2014, had this problem. He had thrombolyzed with tenecteplase at that time. He recanalized in the brain, but he had a cardiac thrombus, because if you see the workup before stroke, echo is not a mandatory investigations to be done before thrombolysis. So this patient suddenly landed up with acute severe pain in the left lower limb because of an embolus sitting in the left iliac artery. This happened within a day of we did the thrombolysis for the brain. So we have to do an emergency embolectomy, and we could salvage the limb. So as Paul correctly alluded to, it's not a contraindication, but you must be careful about fragmentation of the cardiac thrombus and peripheral embolization, for which we need to do about it. Okay. Now tell me, Srijit, can we do a patient who have thrombolyzed in 1916, say 2016? Today he lands up with you with a similar problem in a different vascular territory within the window. What will you do?
So we can definitely proceed with thrombolysis. I think.
Yeah. Please go ahead.
It is happened in 2016, no, long before. So
yeah.
Usually, if the patient had a large stroke very recently, there may be a disrupted blood-brain barrier and a hemorrhagic transformation risk is there if the patient had a very recent stroke. But for a stroke which has happened in 2016, hardly any risk exists. So we can proceed with usual stroke management. But after this acute therapies, we should look back again regarding whatever steps we have taken for the secondary prevention and whether we have detected the correct mechanism of stroke.
Bobby, what is the correct investigation in this setting? Two vascular territories, two different times, a vascular ischemic event. What should be the investigation of choice, and what's a possible underlying mechanism?
Did you say two strokes, sir, at different times?
Ischemic strokes, two different vascular territories, and lands up this thing. What should have been the investigation? He said, no, Srijit alluded to some tests to be done carefully and other thing. What test is ideally to be done in this setting?
So if there are two different vascular territories, and if the vascular imaging does not show any critical stenosis in those areas, which explains the strokes, then definitely one must look for a source of embolism from somewhere else, the most common being either the heart or the aorta. And definitely we should offer the patient either Holter monitoring or a long-term external or internal loop recorder monitoring, as well as, if possible, do a trans esophageal echo to look at the aorta to look for any major plaques or ulcers or anything that can embolize from the aorta. The patient should also look for any clots in the left atrial appendage, and carefully search the heart for any dilated cardiomyopathy or anything else that could possibly cause embolization to two different vascular territories.
Yeah, very correctly said, Bobby. Now, with this question answer session, I think we have covered the spectrum of acute stroke and its management in various settings, including wake-up stroke and concomitant diseases, to a reasonable extent. And I don't see any more questions in the question box. I thank each and every panelist who have sailed through with me in the last 1 hour in the discussion on acute stroke management, for the contribution which was of immense value, which has come at an opportune time on the day of World Stroke, where we want to propagate that patient with stroke should not be neglected even in the COVID era. That's the importance. With this, I conclude the panel discussion, and I thank all the panelists for the comprehensive answers in the various settings, and hereby I hand over the webinar to Dr. Prema for doing the honors. Dr. Prema, please.
Thank you, Dr. Kumaravelu.
As we come to the end of the session, I would like to show our esteemed clinical fraternity who are involved in the management of stroke in various hospitals across different geography in India. We in the state of Kerala, in the state of Karnataka, and also in the state of Andhra Pradesh and Telangana. So we have the teams ready. The teams with their experience and depth and breadth of the clinical expertise have been instrumental, without whom we would not have been able to launch this comprehensive stroke management program. Our teams are stroke ready. Spatika, if you can go to the next slide. So these are the other hospitals. In addition to 3 hospital flagship hospitals, we also have the hospitals in Andhra, Telangana, in Kottakkal, in Prime, Hyderabad, in Bangalore, and in Kannur. So the teams are there already, stroke ready, to help our patients get diagnosed, treated within the golden hour to recover and heal to the best of possible outcomes. The last 1 hour has been extremely useful in understanding the nuances of a complete cycle of stroke management, from a preventive aspect to early diagnosis, recognition, to diagnosis and respond and manage, all with an evidence-based protocolized care. So this has been a culmination of a long and an earnest endeavor, and would not have been possible without the blessing, support, and helping hands from all the quarters. Next, Spatika. So this is the time to actually thank all those who have been instrumental in making this program a success. At the outset, I would like to express my profound gratitude to our beloved chairman for his motivation all the way to this very day of the successful launch. Thank you, chairman, for the blessings. My deepest gratitude to Dr. Malati, without whose constant guidance and dynamic leadership, this program would not have seen the light of the day. Thank you, Dr. Malati, for relentlessly driving this to fruition, be it at the last minute, late night calls and WhatsApp messages. This has been actually helped us to make this program successful. We have been fortunate to have our CEO, Aster India, Dr. Harish Pillai, to share his thoughts and providing guidance, for always being there for guidance and support. Thank you, Dr. Harish. With deep sense and obligation, I would also like to thank Dr. Kumaravela to kindly agree and drive this entire program and moderate today's panel discussion. I must mention his immense contribution, not only for today, but also framing and guiding the entire clinical program. With the same note, I would also my sincere thanks and obligation to our esteemed panelists, to spare your time and enlighten us on the critical aspects of the stroke management. A big thank you, a heartfelt thank you to all of you. It has been also a privilege to have you all as an audience, for your participation and contribution to make this session interactive and meaningful, and to help in the collective learning for all of us. So thank you for your patient hearing. Thank you. Thank you. My heartfelt gratitude also to our technology team, marketing and branding team, to help bring this program alive today. And a sincere gratitude to all who have been directly or indirectly have been helping us to make this program today. Lastly, a very special thanks to our Dr. Spatika for her immense help in stitching together this program by constantly updating and bringing all of us on board daily, almost daily, for a dry run and more of a dry run. So, and then we come to the end now. I must conclude the program by reminding us all our promise of treat you well, and especially on this very special day, the World Stroke Day, we make a commitment for a faster care and a better outcome. Thank you all. Stay safe.
Thank you very much.